This was not at EASL actually, but it came out the week before, so I thought we'd throw it up. It's new evidence on global prevalence of Hep B, much higher numbers than previously. Actually, this is the population of under 5 years of age. Interestingly enough, it's like, look at these numbers here: 500,000 in Nigeria alone. This is over 5 years of age. In millions, actually. So 80 million people in China infected, just approximately. So their estimates were the global prevalence of S antigen in 2016 was about 4%, corresponding to about 300 million, which I think is probably still low. Of these infections, about 30 million were diagnosed, but only about 5 million are actually being treated. So 5 million out of 300 million known, although the numbers are probably way higher than that. So very tiny, single-digit percentage of the Hep B is being treated. These are some other estimates. 260 million. This is why I put this up here, though. 900,000 people die every year, actually, as a consequence of Hep B. A totally preventable disease with vaccines, although not totally curable yet. So, in terms of cure, these are some of the drugs in the pipeline. Here, I'm just going to show you the ones that were shown at EASL, most of which are phase 1B and some in vitro data. But I'll give you the basic. It'll give you the basic feeling about what's going on. TAF, as you know, is approved. Nivolumab is approved, as well. This is the antiviral competitive landscape here. This is the Assembly Bioscience, the J&J, the Arbutus ones. This is the Roche CPAM. This is RIG-I. We did not see any of that at EASL. J&J, Assembly, etc. So lots of shots on goal here. They're not going to be, this is S antigen targeting, mechanisms of action. This is Replicor. There was a presentation there I'll show you. GSK, Arbutus. So the reason people are targeting S antigen, remember, is that S antigen excess accounts for shock and awe to the immune system. Okay, it basically overwhelms both the B and T cell mediated immune system and puts it to sleep. They give up. They've been overrun by this antigen, so they give up. So if you can knock down S antigen, probably down to 2 logs or less, you can have a shot of awakening the immune system. And then here's a few more. So there's lots of stuff going on. So this is the Arrowhead one. I had the poster, but I was having trouble cutting and pasting. This is actually from the abstract. Arrowhead is a siRNA administered subcutaneously, which means small interfering RNA. And actually, one dose here lasts about 3 weeks, and the second dose looks like it has even the first dose has a pretty decent tail, actually here. So it hangs around for a while. These things are designed specifically to target particular areas of the genome. This was the poster data here, actually, and it's looking fairly promising. This one was actually pulled back from the market last year because of liver toxicity of the excipient, but now they're back in with a different excipient and they're doing okay. Okay, that's ARC320. So this is siRNA. This is the first Arbutus siRNA. Actually, it's a unique 3-trigger design, so it crosses 3 areas, 3 overlapping reading frames, reduces all hepatitis B transcripts. It's delivered by this lipid nanoparticle technology, which they've just out-licensed to a bunch of different companies because you can use siRNA as genetic gene therapy, and if you pop it, it's hard to obviously inject RNA or swallow RNA. If you put it inside this lipid nanoparticle, actually you can get it to where it's important. So, and actually this can also work synergistically with this RNA destabilizer that they have, which is first in class. This is a lipid nanotechnology particle. I think, Scott, several of the things you were talking about in the future, like the Regeneron, folks are using this technology to deliver siRNAs. So this is 1467. This has to be given IV, but as you can see, it overlaps here, the X chromosome, two S antigen overlapping reading frames, and as well as the polymerase, the core, the E antigen, and the pregenomic RNA. So this is what we've done with this so far. Monthly dosing shows actually a lot of rebound here, so they changed the dose to every 2 weeks. And by the way, this is S antigen over here, so we have to be careful to keep our endpoints straight. S antigen versus HBV DNA. S antigen probably being the more important one. So that
genotype agnostic.
Yeah, these are pan-genotypic. Actually, they're designed to be, to be in the preserved region of the Hep B genome, and Hep B genome is extremely well preserved. Actually, it hasn't changed actually in 600 years. Actually, from the two mummies they dug up recently, one from Naples and one from Korea, and there was exactly the same sequences. They couldn't actually do paleovirology and tend to go backwards because the virus hasn't changed in 500 years. Anyway, so twice monthly dosing definitely causes about a 2-log drop in S antigen, which is usually enough to actually have a significant clinical effect, because it's rarely above 1,000. We can get it below 100 or 10. You give the immune system a chance. So this is promising data, proof of concept. 7 of 12 met the response criteria. 5 of 7 achieved low S antigen levels. There was only one SAE, and that was a hepatitis E infection in Romania, an acute Hep E, actually, which scared the shit out of everybody, but because there was such high AST and ALT. So everybody knows we're probably going to need immune stimulation here, so we're using interferon now as part of the big, fat, gross immune stimulation. Part of these will hopefully be able to use something more sophisticated like TLR agonists in the future, but more proof of concept. So this is the study that's getting started in the next couple of months. So 1467 here, biweekly infusions, daily oral tenofovir, so kind of combination therapy, and then after a 6-week lead-in, the patients will start PEG, and obviously dose reductions, etc. So we'll get the triple therapy here effect and see what happens with S antigen in particular.
Where are these being conducted? Mostly in
overseas, yeah, Poland, Romania, and actually I think this one's going to go to Vietnam. I was just on the phone with the CRO today. So this just goes to show you, we designed this study a year ago, the Arbutus study, and then this year, we haven't started it yet because of technical difficulties, as these things go, and then this study came out actually about a month ago with exactly the same study design, basically. So just goes to show you, if you think of something, you're not any smarter than anybody else, so you better do it fast because somebody else is going to do it before you. So this is the Replicor siRNA with tenofovir and PEG interferon, actually, and this is they have a different sequence, obviously, of the siRNA. Which also blocks CCC DNA. And actually, they had a pretty successful experiment here. S antigen dropped pretty dramatically. Anti-S even actually came up. So surface antibody popped up, which is actually very exciting here. And then 8 of 10 patients actually lost S antigen in the 39 group, and 5 of 10 in the 65 group. So promising, obviously. So we're obviously doing the right experiment with the Arbutus
stuff. Do they have any clues about the difference between the responders and the non-responders?
Yes, interestingly enough. In the early, without the interferon, even actually, the early Arbutus studies, IL-28B CC patients were the ones who responded, actually, which are obviously more common in Asia. So yeah, so interestingly enough, which is a gene that codes for endogenous interferon response, which makes you sort of think we're going to need some kind of immune boosting. So this agent is a little unusual. It's an RNA interference agent. Actually destabilizes RNA. It inhibits HBV DNA replication as well as lowers all HBV antigens. And it's a durable activity with a single subcutaneous dose. So this is sort of the second version of the siRNA. Inhibits replication, proprietary liver targeting, and actually here are the similar pieces of RNA that it's inhibiting to the 1467. So this comes into the cell actually by this GalNAc mechanism. It's a little bit less sloppy than the lipid nanoparticles. It binds to the asialoglycoprotein receptor, the ASGPR, and it gets uptaken into the hepatocyte here, and then it gets broken off, and then the siRNA can do its thing. Longer duration than the 1467. Actually, it has a nice long tail here. This is weeks after administration, so 10 weeks. It still has a 2-log effect on. Actually, this is DNA though, not S antigen. I'm sorry, this is S antigen. Yeah, which is very impressive actually. And it's also pan-genotypic. And next is safety studies. So these are there's a lot of people looking at these, what they call CPAMs, core protein allosteric modulars. So they're looking at, and then they obviously will work on the core protein. So this is the assembly, the J&J, and then Roche, and then Arbutus. This is the Roche one. This is the Roche Shanghai. This is 389 is a class 1 CPAM. There's class 1 and class 2. Class 1 causes aberrant core protein aggregates that are subsequently degraded. Class 2 CPAMs actually provide empty capsids. So there's no functional nucleocapsids. There's no RNA in them. Actually, you'd think it'd be great to do them together, but they have the same binding site, actually. So all they would do would be to compete. So the benefits of this one particular one, 389, is it actually gets taken up through the OATP receptors, so it's transported into the liver, actually where it should work on the bile canaliculus. So in the mouse model, you get a good 3-log drop in HBV DNA in 7 days here. S antigen also actually is down 2 logs, and there's E antigen also down a couple of logs as well. So this is the virologic responses in the early dosing of patients, and actually the ones who had lower HBV DNA, only 4 logs all got to the lower limit of detection while they're on the drug. So it looks pretty impressive. Now this is the combination of the Roche TLR7 agonist. The other TLR7 and TLR9 agonists have crapped out. Actually didn't do well.
If I remember correctly, and I remember Ira presenting this years ago, the patients got incredibly sick. So
some of the TLRs are really bad like that, actually. Some are less benign, and some just didn't work, actually. There's a bunch of them, yeah, and it depends on their side effects. I think it was TLR12 was the one that was really ugly. So this is a combo of TLR12, actually in the mouse model. So this is kind of what a lot of people are thinking: virus-targeted approach plus an immune enhancer. The TLR7 would be the immune enhancer here too. So you knock the S antigen down, and then you activate the immune system at the same time. So it'll be a substitute for PEG interferon, a little more sophisticated version of PEG. It's a prodrug of TLR7, and is selectively converted to active drug inside the liver, so the side effect profile is pretty good. It's not floating around in the serum. Here you can see HBV DNA decline in the mice, S antigen decline here, This is in the wild type mice, but it doesn't work in the T and B cell deficient SCID mice. So obviously it's an immune activator, is the conclusion from that. And then the oral combination with the CPAM and the TLR7 leads to sustained viral. So the combination here looks pretty good. It looks synergistic, and there's treatment end. You can see things popped up here, but this is S antigen, DNA, and E antigen, all looking like they have good responses here. It's kind of amazing how many things are coming. This is the J&J capsid. With they think it has a secondary and a primary mechanism of action. It inhibits it's a class 1 capsid assembly kinetics, but also it may actually inhibit the de novo formation of cccDNA by interfering with the capsid disassembly process. And then all of them might actually do that as well, because apparently cccDNA needs refreshing of pgRNA all the time. So this one is like 3 logs here. This is HBV DNA measurement. So it looks reasonably promising, and they're headed on to U.S. trials, actually, phase 2 U.S. trials.
Patients in the trials generally treatment naive or just treatment withheld?
So some of them are suppressed, are virally suppressed. These proof of concept ones where you're looking at DNA are not on treatment, basically. Well, the people who are looking at S antigen want they're virally suppressed. If you're looking at DNA, you want them naive to therapy.
And what is the strict definition of HBV cure? Is it a standard definition?
Yeah, well, there's 2. There's a functional cure, which means S antigen disappears and either S antibody appears or there's just S antigen remains negative. That's the functional cure. And then the true sterilizing cure, which many people think is the holy grail, may not be possible. Maybe the cccDNA is actually gone, and or the integrated HBV DNA into the genome is gone as well. That's why you saw way back on the left-hand side the CRISPR technology from Co-Crystal looking at that. It might, once we get the antigen negative, then you may want to use some CRISPR to slice out those integrated genes. So this is assembly. Also has a CPAM. Actually, they had a very novel study design. Rich Colono has reappeared there, actually from BMS. And Kash Agarwal was an investigator on this one as well. PK parameters, 1 pill once a day. And actually, it looks pretty good. This is HBV DNA. Actually, a good 3-log drop. This is all patients. E-positive patients have higher DNAs at baseline, so they have higher drops, and then E-negative patients have lower drops, but the slope is about the same here. So actually, we should be, they've offered this study to us. If we can get our act together with the IRB, which has been completely putting the brakes on all of our activity lately, they would like to get started in June on this trial. Actually, actually, it's a pretty good trial because they'll give us a year's worth of drug after the patient goes through the placebo, part of the study. So I think they're going to stop at 200 and 300 milligrams. 400 milligrams, they had a little toxicity signal. So it looks like a really good antiviral. Okay, so lots of people think there's a bunch of different things to do here, not just reducing S antigen and immune therapy, but killing virus at all levels of its replication. So we talked a little bit about the destabilizer here, but capsid inhibitors work down here to inhibit the capsid assembly over here, and then the nukes are over here using preventing DNA synthesis. So obviously the idea would be to use triple therapy with 3 different mechanisms of action. So this Arbutus drug is actually class 2 inhibitor. It's on this side here, and it prevents retrotranscription. So this is it's slightly next generation. The EC50s are much better than the other ones that were previously described. Dose responsive antiviral activity. You can see here it's 3 logs at 100 milligrams. This is the potent RNA destabilizer. It's a small molecule inhibitor of HBV replication. It destabilizes RNA at a bunch of different levels, actually. So it has sort of several mechanisms of action in one, because wherever it sees RNA, it actually destabilizes it. That's the 452. So triple combinations of the CPAM, the core protein, the RNA destabilizer, and tenofovir actually are giving you a good solid 3 logs drop in HBV DNA in 7 days, actually. So that's way faster than any other sort of triple combo. So this is the kind of thing. So the big bet is actually whether dropping the virus with three different mechanisms of action like this rapidly enough, and dropping the S antigen rapidly enough will restore immunity so that you don't need an immune booster, or whether you'll need an immune booster anyway. So we don't know the answer to that question. I have several bets placed on that. Actually, already, these are the drugs and the synergy curves here. Most of them are at least additive, if not synergistic, because of the different mechanisms of action. And actually, that's about it. So it looks like there's lots of activity in this space, lots of clinical trials. Some of them are coming to the U.S. Actually this summer. We hope to be able to enroll some patients in that one, as well. So any questions on the Hep B world before I?
So Doug, in terms of clinical trials, you and I are old enough to remember that Hep B trials needed to be covered by biopsy.
Yeah.
Viral load and surface antigen became suitable endpoints. Does that still hold true for these?
No. No. Fortunately, these are in the antiviral committee, of the FDA, so they're perfectly happy using viral markers actually. Yeah. With quantitative S antigen, E antigen, all those markers. Plus, actually, most people are also taking immunologic data as well. So they're measuring B and T cell function along the way, so they can try to predict if we're going to need something, some booster.
I guess the challenge will be durability of any of these effects, and none of these studies really are addressing that.
No, some of them have a nice long tail, which means that the inhibition, might last for quite a while. Right. The question is whether it'll last long enough for the body's immune system to wake up and clear the virus out. We did that successfully with Hep C. We're able to suppress the virus so effectively that the immune system wakes up and clears the virus. So the question is whether we'll be able to do it with Hep B or not. Yeah. Okay. Good.
Okay, there's seats up here. So I'm going to focus on the Nash activities, but I'll make some general comments. So it was a busy week in Paris. I, of course, never caught any of the Hep B stories, so I came away thinking there was nothing but Nash at the meeting. So I'll review some very impressive short-term effects with Madrigal and NGM. One issue that's confounding all the clinical trials in Nash is that the longer you put a patient on a drug for Nash, the better the placebo patients get. And no one has explained that exactly, except that it seems most likely that patients who are obese are coming to the doctor more frequently, and whether they intend to or not, are more compliant about diet and exercise. There was actually, I'm not going to review it here, so I'll mention there was a nice study from Arun Sanyal looking retrospectively at the features of placebo groups in multiple trials that might predict that they would or would not get better spontaneously. And not surprisingly, those who had an elevated AST at the onset of a trial in a placebo group had less likelihood of responding, or I should say, getting better spontaneously. There was, as is now the case with ASLD, there was a huge pharma investor presence. I actually spoke at 3 different settings. One was for Novartis, one was for Galmed, and then I gave a state-of-the-art lecture on drug development, which I'll give to the division here sometime in the next year. It was a lot of fun, and I learned a lot from putting the talk together. I actually, Doug, you can have your own opinion. I actually find the meeting more exciting and dynamic than ASLD, and even though I'm a past president of ASLD, I have admonished ASLD that they are falling behind in sense of the branding, the dynamism, new approaches to the meeting, better tech presence, all of which EASL is now clearly outdoing ASLD, and they serve food, which is even better. I don't know what the attendance numbers were, but it looked every bit as much as ASLD, which is somewhere generally around 10,000. Paris is always lovely, but the venue was really remote and huge. It was a 20-minute or 30-minute subway ride to the real Paris. So as I mentioned to several people, it was really nice because the meeting was really, it was nice that it was near Paris. It wasn't actually in Paris. But the problem, of course, is when you have a meeting of 10,000 attendees, there are very few convention centers that can accommodate that size. And next year is in Vienna. Last year was Amsterdam. So I think the cycle is something like Barcelona, Paris, Amsterdam, London. And at one point they were in Milan. I don't know if they're still going to go back there. So next year it's in Vienna.
Milan was terrible to get around.
Yeah, it was another one that was near Milan, right? Yeah. Not in Milan. Yeah. Okay.
Next year's Vienna.
So let me, I don't have time to go through the whole background around Nash, and I apologize for that. I'll try to fill that in. The story starts for the first drug with a molecule called cenicriviroc, which is a CCR2, CCR5 dual antagonist. One of the points I made in my state-of-the-art lecture is that if you think about it, all the drugs that are currently already in phase 3 have been repurposed from other indications. And in this case, this was developed for HIV because CCR5 is an obligate receptor for internalization of HIV. And so the drug had a lot of safety data. It seemed reasonably effective, although it didn't break through for major use in HIV. Doug, did you ever use it?
I was on the DSMB for all the HIV trials.
Right.
Actually, so I saw a lot of the data. And I think we did one Hep B HIV trial here with MENA, actually.
Right.
For like a 6-year trial.
Okay.
Actually, it didn't really have any side effects.
No, it was very well tolerated. So, as I said, I'll give that talk some other time, but, one of the most attractive ways to get drugs into clinical trials is after they've already been tested for another disease. You have lots of information about their safety. You can often go right into phase 2 trials. So in this case, they reasoned that CCR2, CCR5 was important in Nash pathogenesis. They actually worked with us, and we did studies that we published some time ago looking at the activity in an animal model of fibrosis, and this was in thiacetamide. And it looked active. And that and other preclinical data, plus the safety data, justified the testing of this drug in a very interesting trial. I was actually one of the co-international PIs. It was a phase 2B, and I'll talk about the different trials in a minute, with 3 arms. So there was a treatment group that got a year of therapy, a placebo group for 1 year. For two-thirds of the population was placebo. At the end of 1 year, a biopsy was obtained. One group stayed on the drug, so this group was on for 2 years. This group had the drug introduced. This group remained on placebo. So you could see both whether 1 year of treatment was 2 years of treatment was any better than one, and whether there was an additive effect because the drug proved effective at 1 year. So these were the criteria. We could have a whole talk about entry criteria for Nash trials. It's in very rapid evolution, but this is pretty standard. Fibrosis stage 1 to 3 with a Nash activity score, NAFLD activity score greater than 4. They were enriched for type 2 diabetes, obesity, and at least one criterion of metabolic syndrome or bridging fibrosis and a NAFLD activity score greater than 5. And they stratified based on NAFLD activity score. It was here in the US, I think we were site, as well as EU and Australia and Hong Kong. This was the phase 1 data, the 1 year data that we published last year. And what it showed was similar to what you're seeing here actually similar. So long story short, the drug had no impact on NAFLD activity score, and yet it doubled the response rate for fibrosis after 1 year. And this was really exciting because it actually was the first time that you could suggest that a drug could have a direct antifibrotic effect without really affecting the underlying features of NAFLD. So this was one of the endpoints. This was a secondary endpoint, but in the end, it doubled the rate. Now, no one should be, super excited about this. It was exciting for proof of principle there, but when you look at a response like this, with 20% response, it means 80% of the patients aren't getting any response at all. And that's why this drug and other drugs are immediately looking to combine. There was a little bit of combination therapy data that was presented from Gilead that I'm not going to review because, in my view, it was just way too early. It was 3 months of non-invasive assessment. What happened is for patients that were treated for 2 years, I didn't show you, but the patients who were treated for the second 1 year period had exactly the same response as a patient who were treated for the first 1 year period. Unfortunately, 2 years of therapy didn't double the response. It stayed like this, so it stayed at 26%. But here's the problem: is the patients who were on placebo had almost an equal response. So this is really a problem for NAFLD studies. It looks like the sweet spot in terms of duration where you can continue to separate the placebo from the treatment response is going to be about a year. But what I'll show you is data that suggests you can see biopsy results in as little as 3 months.
Oh, mine is like Weight Watchers.
How so?
Well, because the patients you're coming in getting weighed.
Yeah, exactly.
Like they're seeing the doctor.
So this looks really dramatic, but there's no statistical significance. But there was a greater than 2-stage antifibrotic response, much more common in the drug than the placebo, but the numbers were small enough that there was no statistical significance. One thing that is very reassuring about this drug is that it has sustained impact on systemic inflammatory markers. So this was 2-year data that parallels very closely the 1-year data, which is that there's a sustained diminution in interleukin-1 beta, interleukin-8, high specificity C-reactive protein, and fibrinogen. And this was associated with prediction of cardiovascular outcomes. And so at least this clearly shows that there's target engagement and you're affecting the systemic inflammatory response. One of the criticisms of the study, and Ladratzi, who presented these data, was, but there was no change in inflammatory score on the biopsy. But what Vlad pointed out, and what we had discussed many times, is that the way we measure inflammation in biopsy is so crude that you could have wholesale changes in the nature of the inflammatory cells, the cytokines they produce, the cells that are responding, and unless you're counting, and if all you're doing is counting inflammatory cells and they're clustering around areas of injury, you'll never be able to see that. So the idea of assessing inflammation based on biopsy is an extremely crude instrument. We need to do better. So in essence, what they showed is that the year 2 corroborated its 1-year activity from year 1. Twice as many CVC-treated patients achieved a 1-stage improvement in fibrosis, and they maintained this benefit. I didn't show you all that. A numerically greater proportion of CVC-treated patients achieved greater than 2-stage and no worsening of Nash, but this wasn't actually statistically significant. They did have sustained anti-inflammatory activity and had no negative impact on the metabolic features, and it was extremely safe. So I would say this is glass half full. I mean, one thing I'll say which is fascinating, because, unlike Doug, I'm really new to the clinical trial world, and I've sort of gotten dragged into it willfully as our own work in the lab has become relevant for clinical trials. But the pace of change of clinical trial design and conceiving of which targets are effective and attractive and how to combine them has been moving at breakneck speed, so that every trial that's done, we learn a lot. So in this trial, at least for this drug, number one, we learned that 2 years is no better than 1 year. You hit a plateau, which is around 20 to 26%. That, like the other trials, the placebo response starts to creep up, and so future trials are going to have to try to mitigate that by reducing the number, by perhaps selecting placebo patients who are more likely to have elevated transaminase, particularly AST rather than ALT. And of course, this sets up the question of whether this drug is going to be suitable for combination, which is already being conducted. So the drug has been, there's a partnership between Allergan, which acquired this drug, and Novartis, and they're moving ahead with a combined FXR CVC trial. No evidence yet of any synergy, but we'll see.
Did they talk about how much, if the treatment arm had weight loss in their group?
Don't believe they did. Don't believe they did. But that's a fair point, Allison. I mean, if your drug does nothing but lose 10% of weight, which in fact,
the patients are more motivated to lose weight because they're on the trial.
Right, but the drug class that does look like weight loss is relevant are the GLP-1 agonists and also probably the SGLT2 antagonists.
Does that help?
It does make you worry, though, outside of the study, will these drugs do anything?
Yeah.
You mean like this one?
Yeah.
Yeah. So look. It's the analogy that actually Arun Sanyal raised and I embraced is that if you have to think about this the way drugs were developed for Hep C, right? So in the early 1990s, even before the virus was cloned for Hep C, 5% SVR for monotherapy with interferon. Then, really by thoughtful serendipity, ribavirin jumped that up to what, 25, 30%, and then 25, and then interferon was regulated. Then it went to 45 to 60, depending on whether you're in the study or in the real world. And then boceprevir and telaprevir were added on to interferon ribavirin, albeit with a lot of toxicity. Then it went to 75 to 80, and now we're at direct-acting antivirals and game over. I noticed you didn't review any Hep C. There's nothing much.
Yeah, there was nothing new. There was some real-world evidence on GP.
Yeah, it works.
So it's like, yeah, we knew that.
Right, right. So, here's a drug development paradigm with a very clear target, which is not the case with Nash. No question it was a viral target, and yet it took 25 years, 28 years to get to the point where we have curative therapy. So I think it's going to be that kind of incremental progress. But I think we're at the point where we already can move the needle on this disease. You can improve fibrosis. So there are some very famous examples of drug disease targets that defied effective treatment. The two that I always think of is one was sepsis. There were billions of dollars poured into drugs to attenuate the effects of sepsis that ended up failing, and also stroke reduction and brain preservation, which for many years was holy grail and has never been accomplished. So we're already past that point. We know that we can improve the disease, in a reasonable amount of time, over a reasonable amount of time, and the next challenge, of course, will be how to ratchet this up from 20, 30, 40 to the point where you now have 100% response. I mean, think about it. If you see a patient or there's a patient with essential hypertension or hypolipidemia, you have a stepwise protocol so that ultimately you have to manage their blood pressure. Nobody would say, well, only 40% respond to an antihypertensive, and that's the best we could do. That's where we are with NASH. Okay.
One more question.
Yeah.
The previous study, have you checked the drug clearance rate starting of the study at the first year study and the second year?
I don't think so, Sai Divikar. I'm not sure. But why do you ask?
I think the possibility of the drug resistance are kicking in, and the drug clearance is much faster at the end of second year rather than the starting of the study at the first year.
Yeah.
So imagine when you're...
But is that I don't know. Is that typical where you sort of amplify the metabolism?
Yeah.
Interesting. I would have thought that occurred faster, but I'll ask the company. It's an interesting thought. Okay, let me digress to a little bit of experimental work, and then I'll get back to more clinical trials. Much as I hate to review this again, but I always have to keep coming back to this. This next couple of studies from Royal Free UCL involves the role of ammonia. If you remember, ammonia is generated in mitochondria, and it's converted through the urea cycle to urea. This is called these are all sort of urea cycle enzymes, and one of the critical first steps is carbamoyl phosphate. And so, of course, one of the arguments is you have accumulation of ammonia, and that leads to, in part, contributes to hepatic encephalopathy. So this is a study from Rajiv Jalan and his colleagues, in which they had previously shown that loss of urea cycle enzymes occurred in experimental NASH, and that led to hyperammonemia, and actually they ascribed stellate cell activation in part to ammonia, which is a very interesting concept we hadn't really thought about before. Now they went on to say, well, if there's really suppression of urea cycle enzymes, why is that occurring? And they did, in my view, a very cursory assessment of epigenetic changes that might modify expression of urea cycle enzymes. So they looked at the role of promoter methylation and downregulation of urea cycle enzymes in this model. And they also had a reversal model where they gave a high-fat, high-fructose fibrogenic diet. They withdrew it. The animal started to get better. They looked at whether the changes in promoter methylation had been reversed when the disease was reversed. So basically, they showed there was a methylation of the ornithyl transcarbamylase promoter and reduced methylation after regression, and this was in rats. And they also showed that human livers with NASH have a lower OTC protein and enzyme activity with methylation sites, but they didn't really assess whether the human promoter was actually methylated. They just said there were candidate methylation sites in the promoter. And so their conclusions from this study was that there was reversible reduction of OTC activity, which may lead to hyperammonemia, and then in their prior studies they try to link hyperammonemia due perhaps to hypermethylation to enhanced injury and fibrosis. So to me it was a very interesting and provocative story that there may be a new link between ammonia accumulation and NASH. But to me it's unclear how much is actually generated and whether it's really meaningful amounts. The results are largely correlative. They just show there's an association. They don't show a mechanism, particularly not with respect to fibrogenesis. And they didn't do any methylation analysis in human tissues. The follow-on study was the one next to it. They assessed the impact of lowering ammonia in a NAFLD model. So this is the high-fat, high-fructose, I don't remember what this is actually, but these are basically diets that induce NAFLD. And they added an ammonia scavenger that Rajiv Jalan said he has helped develop called OCR. And they basically showed that OCR-treated animals in the midst of this diet had reduced fibrosis, cell death, and ammonia levels. These are actually some of the data. It's hard to see it all here, but this is the different diets. Actually, I'm not even sure what the treatment is here, but I think this is the high-fat, high-fructose for 16 weeks, and then 16 weeks plus the agent, they had reduced fibrosis. The conclusions of this study was that, or the main conclusion was that lowering ammonia in a preventive mode attenuates experimental NAFLD. What I had questioned is whether there's an independent effect of this inhibitor on the pathogenesis of the model by altering lipid homeostasis that has nothing to do with ammonia. They also didn't test it in a therapeutic mode where there's already disease established, which is important. And one of the things we do routinely now when we do these kinds of studies is we include a positive control to benchmark the magnitude of the effect. And typically the positive control we'll use is obeticholic acid, which is of course in clinical trials. Oops, this didn't show up, but what it was a very quick image showing that the presence of decompensation in cryptogenic cirrhosis doubles the cost of caring for patients from $100,000 per patient to $200,000 per patient, as if we didn't know that patients who have decompensated cirrhosis are very expensive. This is a terrific review that came out late last year from Steve Harrison. Steve is a really interesting, good guy. He was a fellow of Brent Tetry. He was a fellow of ours at UCSF. He was in the military for 29 years where he was functioning as a NASH physician. He's now opened basically a clinical trial factory in San Antonio, and he's by far the largest enroller, and he has very quickly vaulted to the top of the heap in terms of leading a lot of major trials, and he does a great job, and he knows a lot. I was on 3 different ad boards with him in Paris, and I learned a lot from him. So this is a nice review on outcomes and endpoints in NASH trials, which I encourage you to look up. Thinking about the different kind of outcomes, what would be the hard, and this is arguable whether it's hard, and what are the things we can measure. So the clinical outcomes you see listed here, these are the things that we might use, and I can't go through all of them for lack of time. Metabolic outcomes, including reduction of liver fat, and now we have really good MRI ways to assess fat fraction plus CAP, and I think the endpoints and the cutoffs for MR fat fraction and for fat from a CAP are now really pretty well standardized. So these are I would say, very reliable endpoints if you're looking to measure reduced fat. There's inflammatory endpoints as well. For this, there's a multi-parametric MRI, also called the liver multiscan from Perspectum. And then for changes in fibrosis score, the non-invasive markers are a change in MRE stiffness and other circulating biomarkers. I'm going to skip this for lack of time. So one of the things Stephen's gotten very good at is pre-screening to ensure that they minimize the amount of screen failures. And he basically defined these 3 groups, which this is kind of easy for patients who have a high likelihood of NASH, those who are over 50, Hispanic, diabetic, obese, hypertensive, stiffness, abnormal AST and ALT. The intermediate likelihood is age greater than 40, diabetes, and then low likelihood here. So, of course, he's in a place where there's, a high prevalence of PNPLA3 risk polymorphism among Hispanics, so he's more likely, which is one of the reasons he's enrolling so effectively. But there are ways, for example, the general consensus is if you're trying to enroll for NASH trials, you should pre-screen for enrichment, at least using FibroScan with a kilopascal of somewhere around 7.5 to 8.5. Probably 8 is a reasonable compromise. CAP score of 288 to 300. And that will already quickly enrich you and avoid doing biopsies if biopsies are required in patients who have minimal disease. And this is a final piece from his review article. Again, I encourage you to look through it. I don't have time to review it in detail, but this is for phase 2A, which are largely non-biopsy driven. Phase 2B are virtually all biopsy driven, as are phase 3 and even adaptive designs. So there's a very thoughtful review, which you can have a look at. So with all that said, 2 trials that probably got more attention than any other. One Mina has been quite involved with. I've been a consultant but not involved in the trial. This is actually a molecule that was developed by Merck and was never, for lipid abnormalities, was never really licensed. Now it's been effectively licensed to a small company called Madrigal, which is run by Becky Taub and her husband. Becky was a Howard Hughes investigator at UPenn. Her husband, Paul Friedman, who's also an MD, has been in industry for a number of years, both very well respected. So it was known for quite some time that a selective thyroid hormone beta agonist had a favorable impact on lipids in phase 1. They've embarked on a phase 2 study for NASH, which is not unlike hyperlipidemia in terms of the overlapping features. This is a 9-month study. They did an MR fat fraction at 3 months and a liver biopsy at 9 months. Here, what they were presenting was a 3-month readout of MR fat fraction in these typical patients with NASH, and the primary endpoint was very smart. It was simply just MR fat fraction, which was a low bar and which allowed them to continue the study. So they're doing fat fraction effects at 3 months. It's very clear you can see a change in fat fraction at 3 months, and they're doing biopsies at 9 months. The results of that will be out probably in May or June. But everybody was really impressed with it's an oral drug, extremely well tolerated. These are basically the key findings based on the MR fat fraction. 63% compared with 18% had a greater than 30% reduction in MR fat fraction. Also, an AST and ALT decrease and favorable effects on lipids, and it was well tolerated. So one rule that I think we're coming to with most NASH trials is if you don't improve the AST and ALT, it's unlikely you're going to see a benefit. So reduction in AST and ALT is necessary, but may or may not be sufficient. So they also collected a lot of other data. The multiparametric MRI, so-called liver inflammation fibrosis score, showed a dramatic reduction in this score, which is intended to reflect inflammation and fibrosis. There's a serum marker called PRO-C3, also showed a decreased trend, as well as an old score called the ELF, or European Liver Fibrosis Score, which was moderately reduced. And what was interesting and thought is actually an on-target and beneficial effect is there was a modestly reduced systolic and diastolic blood pressure. So you may have a drug that has effects on liver fat, on lipids, as well as on blood pressure. Yeah. So what they're saying is that the drug reduces fat and AST-ALT at 3 months. It's very well tolerated. To say that their 9-month biopsy results were highly anticipated would be a massive understatement. For those who follow this, Wall Street has been insanely in love with this drug and this company. And of course, the air could come out of the balloon very quickly, but most people think that the 3-month data that are non-invasive are so compelling that they will be shocked if there isn't a histologic benefit. One of the interesting things is that they didn't really emphasize this, but there was actually more weight loss in the placebo group. If that turns out to be the case over 9 months, you may end up with the same problem again, where you're having a placebo effect that narrows the difference between the two groups. It's really interesting. So this is a little bit like Name That Tune. Name That Tune was a show when I was a kid where they have contestants who would say, I can name that tune in 10 notes. I can name that tune in 9 notes. And then they would play however many notes the last person committed to, and they had to guess what the song was. So it's sort of like that with biopsy duration. So Flint was 18 months. That was obeticholic acid. So they said, I can show fibrosis improvement in 18 months. Then Allergan came along with CBC. They said, I can show fibrosis benefit in a year. Then the simtuzumab ASK1 inhibitor from Gilead came along with a badly controlled trial, but they showed fibrosis benefit in 6 months. What I'm going to show you in the next slide, or in the next study, is now they've gotten down to trying to show a benefit in 3 months. So one of the challenges here is, remember, this is a chronic disease. Why do we need to show a benefit in 3 months? It has nothing to do, in my view, with the long-term treatment. It has to do with all the companies and the investors who are desperate to see some efficacy in short term. And I've sort of tried to remind people that, yeah, it's fine if the investors are happy that at 3 months the drug shows benefit. But in the end, I'll take an 80% effective drug that's beneficial over 10 years than a 100% effective drug that isn't as well tolerated or doesn't work for a long period of time. But this was a very clever trial design because they had an early signal of efficacy at 3 months, a very low bar for hitting their primary endpoint, got lots of people enthusiastic, and they're having a longer-term fibrosis readout with transition to phase 3 based on these results. Because it's a biopsy-based trial, it qualifies as a phase 2B. And so they could easily move to a phase 3 trial if this is positive in the next couple of months. The final drug that I'll talk about is one that really knocked people off their seats, which is an FGF19 analog. FGF19 is a hormone derived from the intestine, driven by stimulation of FXR, and elicits its effect through 2 receptors, both of which bind with beta-klotho, FGFR4 and FGFR1C, and these are the putative activities. Now, what's interesting about this drug, FGF19 is known to be a mitogen. So, it was obvious that you can't give a drug that stimulates hepatocyte proliferation because you could be inducing cancer. So, the company, or I don't know if it was them or people they licensed it from, developed a synthetic FGF19 that has cleaved out the portion of the molecule that drives cell proliferation. So this is purely a pro-metabolic, but not a pro-proliferative form of FGF19. Okay, so this is some of the background. Actually, these are from the company. I'm one of the consultants, so they distributed the slide. They had looked at a 12-week phase 2A in patients who had biopsy-confirmed Nash and showed that at 12 weeks they had a marked reduction in liver fat content, decrease in biomarkers, no significant difference in the 2 doses, and a favorable safety and tolerability. They did see modest and on-target effects of on an elevation of lipids, which they managed with a statin in this study. So now what they did, which was absolutely ballsy, is they said, we're going to do, although not placebo-controlled, we're going to do a 3-month trial with biopsy at the beginning and biopsy at the end. So now name your tune has come down to three months. And believe it or not, they showed a benefit. So this was the trial design. It was the drug for, where is it here, 12 weeks. They had a biopsy at the beginning with these endpoints, more non-invasive endpoints at 6 weeks, and biopsy again with these endpoints at 12 weeks and then 6 weeks later. There was no placebo group, but the efficacy was thought to be so striking that people believe this even though there was no placebo group, and frankly, they are pretty impressive. So the primary endpoint was a decrease in absolute liver fat content of greater than 5%. They're looking as an exploratory endpoint. So again, they don't put all their eggs in the basket of histology because it's a very high bar. 19 patients out of the 22 completed 12 weeks of treatment. A statin, rosuvastatin, was started at week 2 if the LDL rise was observed, and then it was titrated to make sure that the LDL cholesterol was managed. So first they looked at the what's called the pharmacodynamic effect, showing whether or not the drug is actually affecting the pathway by looking at something called C4, which is a marker of bile acid synthesis, and you can see by week 6 and 12, both bile acid synthesis and total serum bile acids were dramatically reduced. This is a daily injection, by the way. So as you think about the universe of therapies for NASH, as astounding as these data are, remember they're not controlled, and they're going to be obligating patients to take a daily injection. It was a dramatic effect in liver fat at 6 weeks already and at 12 weeks, so it tells us that fat can be moved quickly. 100% of the patients achieved primary endpoint of greater than 5, decreased relative fat count, liver fat count of 30% or greater. Amazingly, 63% normalized their liver fat content completely, which is pretty astounding. Rapid decrease in liver transaminases, supporting a reduction in inflammation. So again, without an AST and ALT improvement, it's unlikely you're going to show benefit. They showed a marked reduction in serum fibrosis markers, a reduction in the non-invasive marker or non-invasive test, the liver multiscan, and a very substantial histologic improvement. So this is the percent of patients who improved with respect to NAFLD activity score, steatosis, inflammation, and ballooning. So NAFLD activity score improvement in 84% of this number of patients, and these are the changes at 12 weeks. A small percentage worsened. The fibrosis stage, almost half, 42% had improvement, 47% had no change. This raises the question, if they treat longer, will we capture more benefit in more patients? 11% worsened. So pretty amazing. A 3-month trial. First, that they did 2 biopsies, and secondly, that they showed a benefit. So they've really set the bar now. Sorry?
They also included cirrhotics, which not.
Yeah, which is, so the drug was generally well tolerated. From my perspective, whether this is a viable therapy over the long run remains to be seen, but in terms of setting the bar and showing how resilient the liver is and its capacity to regress fat and fibrosis, it's pretty astounding. So they need to obviously do a placebo-controlled trial. This is just simply showing the potential to impact both resolution of Nash and fibrosis with early histologic responders. Now the question is, with these patients who got worse or didn't respond, are they a different kind of Nash so that their disease is driven by different pathways? Are they slow to respond and you would need to treat them longer? We don't know. I think it's naive to think that every patient who has Nash under the microscope has exactly the same pathogenesis. And I think what we're going to be learning about in the next few years are so-called endophenotypes or subphenotypes that look the same under the microscope but may have different genetic components or drivers and therefore require more personalized therapy. Early days. And all of the histologic, the non-invasive markers moved along with the histology. Very favorable, mild GI symptoms. They did have some diarrhea. They were mitigated by separating the timing of injection. There were 3 SAEs that they felt were unrelated to the study drug. And so this was their conclusion. On-target activity in terms of C4, significant reductions of non-invasive markers, large percentage responding, unprecedented antifibrotic activity, LDL cholesterol elevations mitigated by statin co-administration and very well tolerated. So clearly they're going to go on to a proper long-term trial. So just one other point. This is actually from an analysis by one of the investor companies that I thought was very useful. They compared it's amazing, you go to this presentation at 7 or 8, 9 in the morning. By 6 p.m. there are all these investor reports, so it's just insane. This is one of the better ones. It's basically comparing the drug at 3 months, the Madrigal drug. So there's more potent fat change, but again, this is a sub-Q daily injection. This is a pill. It's very well tolerated. This has more favorable lipid profile. Again, decrease in fat fraction, greater decrease with the NGM, and then all of these other comparators are listed as well. Totally early days. It is an absolute free-for-all in the Nash drug development world. People are scrambling like crazy to develop and test new drugs, and we really need to be at the center of all that. Joe, did you want to present?
In the interest of time.